Good morning. That's your part. Yeah. So thank you very much indeed for inviting NELFT here today. We're very, very pleased to be here. And my job is to speak to you today about emotional well-being and mental health services for young people. And that includes access for those with eating disorders as well. So I'm going to run through a few slides, try to bring alive what we've been doing since September the 1st. Then I'm going to introduce a number of my other colleagues who are going to speak to you about some of the clinical work that we've been doing. So I'm here today to speak to you about emotional well-being as well as mental health services. And that's not an accident that I emphasize that as we understand it, what we're being asked to do across Kent and Medway is reach out to people who are experiencing emotional well-being as well as mental health problems. So that rather than demanding that people are sufficiently distressed or disordered before they access a service, it's actually reaching out and down to people as they start to develop difficulties. This is something that adult mental health services have been doing for a while, and that CAMS services, and our services are no longer called CAMS, are playing catch-up. I suppose it's also worth emphasizing that 75% of the adults who go on to develop mental health difficulties have done so by the age of 25. And 50% of those have done so by the age of 14. It's also worth emphasizing that 76% of children and young people who have emotional well-being and mental health difficulties in the UK don't currently have access to services. And that's in contrast to 35% of adults. So we've got a lot of work to do in trying to reach out to young people who are suffering with emotional well-being and mental health difficulties. So that's what we are trying to do in this area. We started our services on the 1st of September. That's an all-age eating disorder service. That's a young people's wellbeing service in Medway and children and young people's mental health services across Kent. We are trying to modernize those services, and I'm going to go into some of the detail around how we're doing that. And I guess our vision is to try to improve access, but also to try to improve access earlier in somebody's journey as they start to experience distress. One of the things that is in our service specification and is new is a single point of access. And I suppose the most important thing to stress about that single point of access is that it is self-referral. So it is entirely reasonable for young people, no matter what age, across Kent and Medway, to contact our single point of access, either themselves or through their siblings or their friends or their parents or their GP or their school, and ask for help. It's unlikely we will engage all of those people in traditional long-term individual psychological treatment because that wouldn't be indicated. That would be too much. But it is absolutely right that those young people come to us and contact us as a first point of contact so that we can either help them with some lighter touch, lower intensity interventions, or signpost them elsewhere, or indeed start to help them with some more longer term treatments. Self-referral is sometimes avoided by health services. And certainly I have, and you may have had conversations with people when considering self-referral along the lines of, but how would we cope because we can't cope now? But of course, having a large front door that's shut or mainly shut is also a difficult way of running services and hoping that people don't come to you or knock on your door. So I suppose we're flipping that on its head. Our commissioners have been bold and brave in doing that, and that's the service we're running. And interestingly, adult IAPT services grappled with this years ago and resisted going self-referral, and then did, and the floodgates didn't open, but indeed you can self-refer. I can self-refer to IAPT and to my GP, and that's about it, actually, in the health service. And young people in Kent and Medway can refer to what was CAMS themselves. One of the aims of the single point of access, and we started this on day one of Go Live on September the 1st. That was part of our contract, and so it was imperfect to begin with. It is still imperfect, but it is getting better all the time. And that when one is running a good, high-quality single point of access, there are clinicians at the end of the phone who are able to make clinical decisions and able to give advice and able to signpost so that people feel that they've had a positive contact just by calling a number or emailing in. And what we're also able to do is to start thinking about which care pathways, I'll tell you about our care pathways in a moment, but which of our evidence-based care pathways might suit the people who are calling up. So that's one of the roles of the SPA. Early help across Kent is key for us. So Kent County Council run early help services and have been doing so for a while. They're successful. And so our ability to integrate with early help is key if we're going to achieve what we want to achieve, which is to reach young people earlier. So one of the care pathways that we've developed and that we're just about to go live with is one that relates to early help. The clinical care pathways that we are introducing into our young people's wellbeing service and our mental health and emotional wellbeing services are these. So we're clustering types of difficulties that young people have. So there are mood and anxiety difficulties. They're very common, very high volume. There's lots of that around. As I said earlier, 76% of young people with anxiety and depression don't access a service at the moment, yet they have anxiety and depression. And they're out there. We also have a neurodevelopmental and learning disabilities care pathway, a complex care pathway that would be addressing people who are struggling to regulate their emotions, developing psychosis, possibly self-harming. Behavioral and conduct difficulties, that's across the age range. That would be parenting in younger children, and then sometimes in teenagers, people who are struggling with some of their behaviors, which might be antisocial. And as I've said, early help. And I suppose the point of mentioning the care pathways is that you don't have to organise your service like this. Historically, services don't tend to, and tend to organise their services around professional groupings. So you might have some psychotherapists and therefore an internal waiting list for psychotherapy. You might have some psychologists and an internal waiting list for psychology. But I suppose we've seen that work badly. And our view is that if there is an internal consistency to your care pathway, if it's clinically led, you've got a better chance of having high quality, adherent treatments, competent treatments, and maintaining high treatment fidelity. It's an inexact science at best, therefore we would do well to focus our energy and try and have high quality within our care pathways. But happy to discuss that with people if they have strong views. These are some of the difficulties that people might come to us with. I guess one of the things I might emphasize there is the ARMS, the at-risk mental states. So 14 to 35-year-olds, in most parts of the country, have access to an early intervention in psychosis team, which is good. But sometimes those young people are developing at-risk mental states at 12, 13 as well. There's lots of good work in Manchester around this. So we're making sure that we're geared up to welcome young people who are starting to have some odd experiences into our service. Crisis is often an emotive part of what was CAMS. We have been running emotional wellbeing and mental health services in Essex for the last couple of years, and what we inherited there was a service that needed a beefed up crisis service, and we've done a lot of work on that in Essex, and we're starting to do that here as well. One of the things that we benefit from as an organisation is we have our own mental health direct service, which is a 24-hour telephone service that you can get through no matter who you are. You can call up and you will get hold of somebody who will pick up the phone. So there is always somebody to pick up the phone if you contact our service, even in the middle of the night. But one of the things we really need to do in Kent and Medway is to get our crisis offer right. So we've just spent, and I've been leading a lot of this with my senior colleagues, we've just spent the last few months engaging with our new staff team. Everybody came to work for NELFT on the 1st of September. Some people were excited about that. Some people were less excited about that, as you can imagine. But we've been able to articulate our clinical model. We've been able to engage with our new workforce. We've just spent the last 2 months interviewing all of our top people. We've done that with a participation worker, Katie, who's done every interview with us. Us as senior leaders have interviewed every person. You know, we've got new clinical leaders, new operational leaders, and really we've been trying to ask people demanding questions about vision, attitude, and modernising services. There's lots of my commissioning colleagues in the room today, and what they are reasonably asking us to do is transformation, is to try to modernise and transform emotional wellbeing and mental health services across Kent and Medway, and I suppose that's what we see our task as doing, and that involves making some bold decisions like going self-referral, for example. So that's what we're trying to do. In terms of the challenges, I guess, for us, one of them is culture change, that historically some CAMS services have been quite insular, have been quite inward-looking. The irony is that for the last 3 months, we've had to be quite inward-looking because we've been looking at our own new staff team and trying to work out how we can mobilize that team and who's right to lead it. But I suppose there is a culture change needed, in our opinion, about trying to reach out, work into early help, work into schools, and try to reach people earlier so that those young people who we know are out there suffering with anxiety and depression, that we can meet them rather than wait for them to contact us, and I suppose historically hope that they don't, because we haven't got the resource, and it's a finite resource. I suppose it's about opening that front door, but also trying to reach out into the community and with other organisations to see how we can augment what other people are already doing. That's our aim. Staff training is not unrelated to that. So we need to skill up and invest in our workforce so that people enjoy this work and feel skilled to do this work. So that's another challenge for us. I guess in terms of probably a final point around service transformation, all of our staff have a sort of lightweight 4G-enabled laptop that they are issued with right at the beginning of our contract. It's got the electronic patient record, RIO, on it, and everybody has a mobile phone. So the workforce is agile. The workforce can work in here, it can work in this hotel, it can work in the car park, it can work in Costa, it can work in clinics, in hospitals, in GP surgeries. I suppose what we've also done is remove the tiers. So there were still some remaining tiers. Some people will know what CAMS Tier 2 and CAMS Tier 3 look and feel like. There are no tiers anymore. It's a single service. We've banned internal referrals. You can't refer internally. You can have a conversation with your colleague, but you can't refer internally. We are one service. And CYPI app, so Children and Young People's Improving Access to Psychological Therapies, big national program that your speakers this afternoon will be very familiar with. We've benefited hugely from that in Essex and in London, and we want to play catch up a little bit in Kent. It's a great way of training the workforce and investing in the workforce, and at the moment that's centrally funded, so to try to take advantage of that. And I suppose finally, digital innovations. So, we've been working over the last few years on developing apps, developing ways in which young people can contact us, digital online resources. There are lots of people out there who are very, very good at engaging young people, and arguably better than a big blue badge NHS service that isn't necessarily very good at engaging young people, ironically, given what we're asked to do. So therefore, teaming up with other people who are good at that engagement is a challenge that we've sort of put upon ourselves. So those are a few thoughts about what we're trying to do. Thank you very much for having us. I'm going to introduce my colleague Nicola, who's going to step up. Nicola Vince is an assistant psychologist, has been working with our service, was working with the service anyway, and has been working with us since the 1st of September. And Nicola's going to talk about a piece of clinical work that she's been involved in. So thank you.
Thank you, Ben. Hi, I'm Nicola. I'm assistant psychologist, currently working in Canterbury and Folkestone, and from next month we'll be moving into the all-age eating disorders service. I've been working with a young person called Maddie for about a year now under the supervision of a clinical psychologist. We first met when she was 11 and having difficulties with anxiety and with eating. Together, Maddie and I have completed a course of cognitive behavioural therapy with a narrative solution focus. As well as this, the eating disorders team has provided continual support to Maddie and her family. In our sessions, we worked hard to externalise the anorexia, allowing Maddie to see it as separate to herself. This worked well, as we felt it was unhelpful and perhaps unfair to label such a young child with an eating disorder. Instead, Maddie was able to be creative and generate distance between herself and Miss Trunchbull, the name that she chose as she likened the condition to the character in Matilda. Aggressive, controlling, scary, and a bully. Furthermore, it empowered Maddie, enabling her to talk about her feelings more easily and give her family a communication tool that was more helpful to distinguish whether particular behaviours were Maddie or whether Miss Trunchbull was more present and in control. When Maddie was referred to our team, she'd been experiencing difficulties for about 6 months, and this is a relatively short amount of time compared to a lot of the young people we see in our eating disorders clinic. Fortunately, this allowed us to offer her treatment in a timely way. This has shown us that early intervention is crucial. Despite having to manage some very distressing thoughts, the fact that Maddie's eating disorder was promptly noticed allowed us to work with her and her family, preventing those difficult cognitions from becoming more rigid and difficult to shift. Maddie and her family continue to work hard towards recovery, and the amount of effort and determination that Maddie has put into her therapy sessions is something that I hope she is really proud of. It's important to acknowledge that whilst Maddie is now doing well, it's fortunate that she's had access to such timely and intensive support. At the time of Maddie's referral, I'd recently qualified in low-intensity CBT and therefore had a lot of time to offer. I'm so pleased that I could dedicate this time to Maddie, but it's something we should be able to offer all young people, something which is prevented by high demand on services and few resources. Also, as an assistant psychologist, I also have a much smaller caseload than most of my colleagues, which made this easier. The benefits of working with young people over a longer period of time were evident, especially given Maddie's young age. We could take the time to identify her feelings and see how these link to her thoughts and behaviours. It also allowed us the time to make often difficult changes. I'm hopeful that offering psychoeducation and talking about these things will help Maddie throughout her adolescence and into adulthood. To me, that's one of the benefits of working with young people, as I hope we can give them tools that will last a lifetime. Throughout our work together, Maddie took it upon herself to write a poem about her experiences. With her permission, we would love to share a recording of this with you now.
The Mental Monster by Maddie, aged 12. It could happen any day, and it isn't fair in any way. If you could, you'd run and run and shoot this monster with a gun. Straight in the face, right there, right then take big breaths again and again. It's not that easy, I'll have you know. If it were, then people would just let it go. Let it fly away, high up in the clouds, watch it disappear without a sound. But it's like glue, and it sticks to you. Even if you wiggle and wiggle, it's a permanent squiggle. It does not fade, it does not go, it stays with you until you can control. The thoughts and feelings that flow through your mind, let them loose, leave them behind. Then you're free from the monster, it's gone for good. Now you don't have to hide beneath those beautiful eyes, because you are the best you could ever be, and that's what matters to everyone and me.
Thank you.
Okay, do we have Brid here? Here we are. Brid Johnson is joining her colleagues on stage. Brid is the Integrated Care Director for the same service. And once again, thank you for that very clear and engaging presentation, made all the more powerful by the example of the service user experience. We've got some time for questions. Have we got everything on Slido? We do? Okay, here we go. So, is work taking place with Kent and Medway's schools to raise awareness of mental health issues and to promote the single point of access? Who'd like to take that?
I'll start, and I'm sure Ben will join in. Can you hear me? Yes. So we have, to be honest, for the first months, we have been quite internally focused because we really needed to get a safe spa up and running and stabilise the staff, transfer the patients over safely, and we have slowly begun the engagement. But I think it's fair to say that we haven't done as much engagement with schools as we would like. What we will be doing is introducing a sort of a senior leader who's going to be working with the head teachers. So we've been engaging with the local authorities to try and join in with some of the established forums that are already in place so we can begin to hear the feedback locally on what are the areas you would really appreciate our engagement on. We've got lots of learning from elsewhere that we could introduce quite quickly, but what we need to do is meet the needs of local schools rather than just bringing in projects and pieces of work we've done elsewhere without checking the priorities.
Okay, thank you. There's a question from the floor. If it's related to this and quick, we'll take it. Needs to be quick, though.
I'm a GP. Can I ask, and with tongue-in-cheek suggest, I heard from Nicola about eating disorder, can we include addressing obesity? And this is not my just personal observation. 5 years ago, this was discussed widely at Medway CCG, PCT, CCG, that this is a big opportunity to address because of emotional problems in children. And if I can also say that in Radio 4 it was mentioned that in Qatar, every adult is going through diabetic screening. So couldn't be a better opportunity to tackle children obesity at the same time.
Thank you for that. Who'd like to respond?
Hello. Yeah, I mean, it's obviously a very pertinent issue. I guess it crosses adults and young people. We have a brand new sort of all-age eating disorder service that we're recruiting to at the moment. Our main focus will be anorexia nervosa, bulimia nervosa, binge eating disorder. But obviously we will meet people who have problem eating, and some of those people will present as obese. We will also meet people who present as obese, into our self-referral CYPMHS and YPWS service. And sometimes that obesity might relate to emotional well-being and mental health, in which case it's comorbid and we can see that group of people. At the moment, we're not being commissioned and asked directly, to be honest with you, to address obesity, but no doubt other services are. But you're absolutely right, there will be comorbidity and we'll address that as best we can.
Thank you very much. Our next question is, how can you support the 76% of young people with anxiety or depression who don't or don't want to access services?
I mean, I'll start, and I guess that links to the first question, because what we see is the vast majority of children, young people, most of their waking day, or quite a number of hours, are actually spent in school. So that's why the importance of building the capacity in the community through schools and also out to general practice and making information available for people. There's a couple of additional things. I mean, Ben mentioned digital. So we'll be developing an app. We've already developed it. We hit a little, probably fair to say, a little glitch on licensing, but that's all moved on now. We're just piloting that in another area to find some of the pitfalls, and then that will be rolled out across Kent. That is designed, Kent and Medway, that's designed to make sure that even if you're not a user, you've got access to something that's got some reassurance that what's available is actually evidenced and checked, if you like, by clinicians. The second thing we've got is what's called Big White Wall, which is an online psychological therapy provider. Again, those licenses will be available through schools. And I guess they're just the beginning of lots of pieces of work we need to do throughout the county to raise the profile of mental health, emotional well-being. The other key area we're working on is early intervention. So I don't know if you're all aware, but the SPA across Kent is we deliver it jointly with the school health service. And that again is about trying not to have a closed door, somebody coming to us and then we say, no, it's not us, it's someone else. It's about us working collectively to say, yes, we've got some ideas. Probably the other area we still could really do with some help on, and we're working with commissioners on this and the local authority, is about getting some fantastic directories of services in place, because sometimes we are not the right place, and we anticipate getting about 20% of calls that are for somebody else. But what we want to be able to do is efficiently, confidently signpost people. And in an ideal world, if we could get to a point where our SPA staff had a little bit of extra time, it would be to ring that individual back in maybe 4 to 6 weeks to say, did you get the help you needed? And that's something, you know, I can't see we're going to have the time to do the next year, but that would be something we would aspire to do. So it's not just those who need these services at what would have been the traditional tier 2 or 3, but actually the much earlier on, early intervention is our priority.
Thank you, Brid. Do we have another question? In terms of crisis services, what plans do you have to improve available places of safety for young people?
I mean, I'll make a start and Ben might want to add. We've been working with colleagues right across the county to look at how we can change the model we've already got in place. We've submitted a bid working with the commissioners and with SLAM to create a new place of safety. We are waiting for the outcome of that bid because that will require some complete remodelling and creating a new service, if you like. We are just at the phase of working with KMPT and the commissioners to look at how we can have a plan B, so something really comprehensive shouldn't plan A work out. So I suppose I'm going to be honest and say it's work in progress.
Ben, did you want to add anything?
Not on that one, no.
Okay, in that case, can I ask you all to thank our speakers, please?